Well, good morning, everyone, and thanks for coming to this great experience. I call it an experience because what you're going to be doing today is experiencing things you may not have experienced before, not only from a knowledge perspective, but really from a how to learn perspective, right? Endoscopic surgery is different from other surgeries because it's very tactile, it's three-dimensional, and you have to use your eyes to understand what's going on as well as your fingers. So it really is an experience kind of concept. I did my first spine surgery, endoscopic spine surgery in 2005. We started a basic advanced sort of course with ISAS in 2014 with Tony Young and I. And so that was one of the first courses that really sort of tried to, bring this knowledge base to the bigger crowd, if you will. One of the first things that I learned was medial branch rhizotomy. I saw Dr. Young do it in his office, in his clinic, many times, and his patients did very well. And that was my first sort of like connection with endoscopic spine surgery. And from there, I grew day by day, year by year, as to what I was able to do. These are the patients we see every day, right? These aren't the sort of special, meningioma patients in the cervical spine. They're not the, zebras. These are the things we see every day. And so in my office, before I learned how to do rhizotomy, it was sort of, okay, go see my PA, go see this or do that, get injections. I would kind of not be able to really reach out to them and touch them the way I wanted to. And so when I learned the rhizotomy technique, I was able to really help them in a more elevated level. And we'll get into that a little bit later. Other options include, fusions and bigger surgeries, but in these older patients where they have softer bone, their endocrine system isn't so good, their healing potential is not as good. We rarely want to do big fusions on these patients with lumbar facet problems. And so this option, I think, is really, really good. It's ambulatory. It's an outpatient procedure, and you leave the door open to other procedures if you have to do it. Obviously, the evaluation is a critical part of this whole concept. And so you want to do a good history and physical, examine them, actually have them stand up and show me, where's the pain? Point to the pain generator. They'll say, oh, I have back pain, but it's somewhere in the thoracic spine. It's not in the lumbar spine at all. And so you really have to, be careful with your examination and history with the patients. I get a 4-view x-ray on everybody just to see alignment and, instability patterns. And then I do perform blocks, facet blocks, medial branch block on all these patients. Just to make sure that, there is some relevance to their pain. This could be SI joint pain, right? It could be other things. And so you want to kind of give yourself a little bit more information if you can. From a literature perspective, the literature has been positive with this procedure. The complication rates are low to minimal to none. There was a recent study that looked at a broad sort of meta-analysis on these patients, and the correlation between positive outcomes was very strong, and the complication rates were like I said, almost zero with this procedure. So as Mazda alluded to, this is a procedure that you can learn and take your time. You can get your OR staff accustomed to endoscopic spine surgery. You could get your anesthesia staff accustomed to doing awake surgery, because we do these with MAC IV sedation, right? And so a lot of times your anesthesiologist is not used to doing awake surgery in spine patients, right? So these are the sort of easier patients to do. You can also do these under general anesthetic in the very beginning, right? If you want to do a general anesthesia, you can do that for these patients when you get started, so you can take your time. From an anatomy perspective, the medial branch is actually 3 branches. It's not just a single branch. There's a medial, middle, and then lateral branch. Each one of these branches does innervate muscle, right? So the medial branch does innervate some of the multifidus muscle posteriorly. It's a very, very minimal proportion of it. The lateral intermediate branch usually does most of that. So you're not really denervating the muscle, but there is a muscle component to it. Each branch will innervate the proximal and distal zygoapophyseal joints. So say you have an L4-5 facet arthropathy, right? You've got to do a rhizotomy of the L4 and the L5 medial branch to get the L4-5 facet joint treated. If you probably haven't seen the medial branch up close and personal, I'm going to try to show you some videos and things and what it looks like so you have an idea of what to look for. Sometimes you don't see it though because it's very small and it's really, really sort of connected to that transverse process. And just carefully dissecting on top of the transverse process, sometimes you release it and you don't even know you've done it. So we'll see that in the lab as well. The equipment is really basic. You don't need really a whole lot of tools. I don't even use a forceps that often myself, but really that's all you really need. And the endoscopic bipolar is like a bipolar that you're used to using in the operating room for open cases. It's the same sort of technology, but this is endoscopic. It has a steerable point, so you can move it around to get to places like on top of the TP or below the TP, very simply, and you want to use that. The power is generated through a box and it goes out into the tip. This is the medial branch right here. It's this, and so I'm using the bipolar, and here's the medial branch. The transverse process is right below it. Heads to the left, foots to the right. And you can see it's very easy with the bipolar. And then you'll work your way medial. I'll show you some more videos in a minute. But it's really not that complicated once you get to feel. The biggest part is just tactily feeling the transverse process and docking your cannula on that transverse process. So, again, there's the nerve. You can see I'm kind of outlining it there for you. And again, the bipolar will go right through that. I usually don't do more than 2 levels at a time, so like L3, 4, L4, 5, because you can't get some retrograde dysesthesia if you do more than that, because this nerve is directly connected to the DRG, right? And so you don't want to do it too many levels. Okay. So the technique, again, general anesthesia. I use a single incision for most of my patients. So if I do, say, 3, 4, 4, 5 or 4, 5, 5, 1, I use a single incision. And I angle my obturator and cannula up and down to get to the different levels. You can do separate incisions, especially if the patient's awake, right? You do separate incisions over each of them and make separate incisions. But I just make one incision usually. I'll show you a picture in a second. I use a short scope and a steerable bipolar. At the end of the case, I use Exparil and Toradol because I do all my cases as outpatient. They go home the same day. They don't stay in the hospital. So this is a patient that, again, a single incision. These are the medial transverse processes of, say, L3, L4, L5, and S1. And so I'll be able to make a single incision and angle up and down to get to these 3 different levels. And this shows how I angle the obturator up and down to get to the different levels. These are some videos. So I mark off the medial aspects of the transverse process. Status post a prior lumbar laminectomy infusion with adjacent level L5S1 degenerative facet disease. Off obturator. I say off, you get off. I'm going to place the obturator down through the fascia, down to the transverse process. A lot of this I do with feel. So I'm touching the transverse process, proximal, distal. You want to be at the superior medial aspect of the transverse process right there. Off. So this is important. So when you take your obturator and you're going down to the transverse process, right? You want to make sure, obviously, you're not too deep. And so you can do this under fluoroscopy in the lateral projection if you want to. I don't really use a lot of X-ray for this case, except for like verifying and documenting where my obturator is, just for medical legal purposes. But as far as I'm, docking my obturator, I do that all with my hand and my fingers. So I'm going to feel that transverse process, superior, inferior. And so now I'm down in the transverse process, working from lateral to medial. So I want to work up towards the facet joint, and I will denervate some of the lateral capsule as well, with the same bipolar. once I'm done doing the rhizotomy portion of the case. Okay. This is.
Now I'm with the superior aspect of the L5 chambers process confirmed with imaging. Go distal off.
So this is just L5S1.
So now I'm palpating the chambers process, superior aspect chambers process. I'm going to use my bipolar and feel the.
So now I'm feeling the superior aspect of the chambers process.
The chambers process, the lateral aspect of the facet joint.
And now you can see almost the whole chambers process.
And I do some capsular ablation as well. And this is the chambers process. Right here.
So at the end, you should see this sort of picture. That's the lateral mammillary process is here. You don't have to see that every time. Chambers process and the lateral facet joint.
Right there. This is the mammillary process right there. Okay, off over there. So now I'm with the superior aspect of the L5.
Okay, so
L5 is going on the patient's right-hand side. This is the medial branch right here. So I'm going to ablate the medial branch just like that.
it's really that simple. Once you learn to do this, it's going to be like you can do it in your sleep. We showed you that video already, so you need to see that. Now, another interesting sort of add-on to this procedure is that I usually, if I have a grade 1 spondylolisthesis, I'll do an onlay fusion, again, through my scope. So what I do is I take a burr, and I'll burr the chambers process, say L4 and L5, and then I can lay down sort of this, I make a little taco, if you will. I wrap some fibrin spin down PRP around an allograft, and then I'll put that down my cannula, starting proximally, then working distally. So you can actually do an onlay fusion after your rhizotomy, depending upon what your anatomy and your pathology is. And this just shows that I wrap it around, I suture it down on the little bone, and then I'll slide it down, and it lies on top. I don't usually use a screw or any concept like that, but that's what I do for that. And this just shows some of the techniques for this fusion sort of concept. So the first thing is the rhizotomy. Then I use my burr to burr the chambers process. And then I take my bone graft and place that down.
Got it? There. Got me going in here. Gonna take a plunger.
Is this part of your endoscopic fusion procedure?
Well, yes, I'll do this if I do an intervertebral, but this is just more onlay.
Yeah.
Yep.
Got it?
So we've looked at over 33, we've now up to like almost 70 patients, doing this technique, and they're all grade 1 spondy patients with the PRP. We haven't had any infections. OR time's pretty small. All the patients are discharged the same day, and no revisions. This is a case I just did. 88-year-old male. I did him on May 23rd, so right before I took off on my plane to come to wonderful Zurich. And this is his follow-up on the night. Oops, sorry.
Yep. This is patient RM. He just had his rhizotomy done on May 23rd, 2025. Today's date is
The 9th of
June 9th,
June 9th,
2025.
correct.
Tell me about your pain before you had the rhizotomy.
I literally spent thousands of hours of middle level pain, 24/7. I was sleep deprived. I could not relieve it. I actually had an ulcer from exceeding NSAIDs, and I had to go to the hospital for 2 months to get rid of that, which was by taking too much ibuprofen. I resorted to looking all over. I tried to find a means of getting it. I was going to go for aminoplasty, but Dr. Yu decided that he could resolve my issues doing a rhizotomy. I did have ablation prior to that, but it was RF ablation. He said he could do it with a laser. I just am overwhelmed with the relief I've experienced, and I look back at all the time I've wasted going seeing medical people and rehabilitation. The sleep deprivation I've had was beyond help. I could not. I went to bed with pain, woke up with pain, was constant pain. My last pain pill I took was on June 1st, prior to my sister's 90th wedding party we had. And it's just unbelievable what I can do. I've done something I haven't done in 15 years. I've been able to stand erect.
Let me see you stand up. Wow, very good.
And the thing is, it's amazing. 88 years old, and you've achieved something that I haven't been able to do in years.
Great.
Thank
Good
you.
job. Okay, fair enough. Yep.
So, you're not going to get this result every time. Obviously, it's not that, easy. But you'll see a lot of your patients, especially the older patients, will be very, very grateful for what you've done for them, because it's just really, a minimally invasive procedure with minimal downtime, and it's overall very good for them.